I want to welcome you to the ATSU Case-Home Founders Day program. And we've been doing this CME program starting this morning all morning. We're going to do that for the next 2 or 3 days, actually. So a lot of activity for us. I want to mention to you folks that are here and listening and watching that this is kind of an annual thing that we do. It's attending Founders Day lecture that we've done for years at this facility, at this school. And so I want to thank you for everybody being here and showing up and your interest and involvement in this presentation and program in general. We have a special lecture always for this presentation. And this year we are honored to have Lisa DeStefano, DO, present the 2012 Fred C. Tinning, PhD Founders Day Osteopathy Lecture. The name of it is Alteration of Function versus Disease, Preparing to Care for Your Patients in a Turbulent Healthcare System. As an undergraduate student, Dr. Stefano studied at Michigan State University in East Lansing, Michigan, earning a Bachelor of Science degree in physiology. She's committed to osteopathic care. She graduated from Michigan State University College of Osteopathic Medicine in 1993 and obtained board certification in both osteopathic family medicine and neuromusculoskeletal medicine, osteopathic manipulative medicine. Currently, Dr. DeStefano serves as the department chairperson of the Osteopathic Manipulative Medicine Department at the Michigan State University College of Osteopathic Medicine. Dr. DeStefano focuses much of her academic and clinical effort on cervical spine function and has dedicated much of her research to sacroiliac and lumbar spine palpation. Dr. DeStefano has received numerous awards, including an appointment to the Board of Trustees of the American Academy of Osteopathy. She belongs to several professional societies. I'd like to thank Dr. DeStefano for being here. I ask a warm welcome for her as she gets ready to speak to us. Thank you.
Thank you, Dr. Strait. Well, wonderful. Well, I want to thank the faculty, staff, certainly the students here at ATSU for allowing me to be here and to chat with you a little bit about my topic for the Tinning Osteopathy lecture. I want to also thank Dr. Fred Tinning for giving me the opportunity and nominating me to do this lecture. My understanding was that he was not able to be here today, but he may be Skyping in. So hi, Dr. Tinning, and thank you. I'm spoiled. I see all the white coats. This is very cool. So, and I also understand you folks aren't expected to wear your white coats for every lecture, so this is quite an honor. Thank you. Thank you very much. So, my topic is very near and dear to my heart. When I look at patient care and the future of patient care, in particular the future of patient care for you folks as you begin your career in osteopathy. And I want to begin by talking a little bit about the rising cost of healthcare. This is a graph of the rising cost of healthcare within America, and we are the top red line. And we're looking at it between the years of 1960 all the way up to 2008. So there's no question we've kind of had a few little hiatuses. I don't see a lot of drops. We've seen a little plateaus here and there, but no declines in healthcare. When we look at the cost of healthcare from this pie, we also see that there are large chunks of care, of costs, in particular when we look at hospital care and then physician clinical services. Now, and then everything else is smaller pieces of the pie along the left side here. What's not delineated here is the difference in cost between clinician services, physician services, and labs and technology in either the inpatient or outpatient areas. And that's sad because that would help us to understand somewhat of where the pieces are cut. Because what we do know is there's a few things in particular that are driving health care costs. And this is the economist's view of health care. Medical economy is quite an interesting topic that I like to read a lot about because it determines my future as well. Number one, there's a rise in chronic illnesses, which I think we'll come back to quite a bit. There's tons of administrative costs within healthcare today. And then the bigger piece is the increase in cost for technology and prescription drugs. Now, when we look at the technology and prescription drugs piece, we need to look at different areas of America. And there are some areas of America where physician responsibility has been called on the carpet in terms of helping to lower the costs of our use of radiology, our use of a lot of examinations, a lot of technology in order to come up with a diagnosis. The increase in costs in technology and prescription drugs is going to be more and more over the years physician accountable. Right now there's certain areas, but physicians are not held to be accountable for the studies that they order and the prescription drugs that they prescribe, nor are they held accountable for the amount of referrals they do, excepting in little subsets of the areas in America. Kaiser Permanente is one area where physicians are held accountable. It's becoming quite trendy. And in the future, my expectation is that physicians are going to be held very responsible for these costs. Now, one would say that tort reform has a big impact on that. Tort reform being the attorneys and their role in physicians' decision-making based on malpractice suits and so on and so forth. Tort reform has happened. It's happened in many areas of America, and there's really no clear evidence that getting tort reform or limiting the amount of attorney influence on malpractice has really changed what we as physicians are doing in terms of prescribing medication and ordering tests and doing referrals. So this tells me that because there's not a big change in the cost, makes me suspicious that it's because of what students are learning in medical school across medicine in America. And what we're learning is even if we're allowed to have tort reform, it doesn't change our practice. So it's inherent to what our future education, it falls back onto our young students' education to learn a little different perspective. And this is kind of my theory. The fact that growing cost of healthcare is unsustainable, which I believe it is, and that's my personal opinion, has huge implications on how physicians in training may be learning how to care for their patients. So the rising cost of healthcare is going to impact you folks, because how you learn how to practice medicine may change in the future. If you're held more accountable for the things that you do, it may not be how you're learning, or physicians in training, I'm talking allopath as well as osteopathic physicians, all physicians are learning currently. Remember, you guys have at least 6 years before you're out, 6 years to 8 years before you're out and practicing medicine, a lot of time. Healthcare is at an all-time high currently now. When we look at how our patients are treated in medicine now, I'm generalizing. The great majority of our patient presentations can be attributed to altered function and not disease, a great deal of them. All right? Although equally disturbing to the patient, equally disabling to the patient, they still cannot be classified as disease. There's no, usually if it's an altered function versus a true disease, there's no clear-cut pathology or etiology. Most diagnostic tests are inconclusive, but commonly are done to rule out the true pathology. Most medications are prescribed empirically, or let's just give it a try, trial and error kind of thing. Most patients are given a symptom complex diagnosis when they walk out of the clinician's office. which they understand to be disease. Our patients are given, a patient I saw on Tuesday, who happens to have a early onset connective tissue disease, was so angry because she went to see, finally got to see a podiatrist for her foot pain, and he told her what the problem was. She has plantar fasciitis. And she believes, her belief was that plantar fasciitis is a disease, and that there's something that he can do to cure that plantar fasciitis, when in fact plantar fasciitis is a symptom complex, altered function. Okay, so she left very frustrated when I told her that it's just a component of her connective tissue disease, and that there's more going on that meets the eye. The other thing with this disease model of patient care, and that's what I like to call it, is disease model of patient care. It's costly, it's confusing, and it's frustrating. It's frustrating for our patients because they don't know that it's trial and error from our perspective. They don't know anything else other than what we're telling them. We're not educating them about the complex of the scale between altered function and the symptoms implied with altered function versus pathology and disease. And there is a cascade. In the meantime, if with all this rise in technology, with all these new medications, you would expect by now we would have a handle on the chronic illnesses. And yet chronic illness is still on the rise. These are the big five: heart disease, obesity, diabetes, arthritis, and cancer. In no particular order. And they're all still on the rise. We don't have cures. Now, when we look at the illness complex of our patients, there's normal function, there's symptoms indicating altered function, and then there's disease. On the pathway to disease, oftentimes there's altered function, oftentimes there's symptoms. On the way from normal to altered function, oftentimes there's normal again. Many symptoms go away on their own without a clear etiology, without a real clear understanding of what has happened or why. Not everything becomes disease, and not everything is disease. I surmise that there's a different way to look at our patient. Our patient should be looked at according to function. If we think about medical school learning, we're looking at many aspects of medical school learning. You should be learning and could be learning about normal function, and I know you folks are. Organ function, systems function, neuromusculoskeletal function, regulatory function, homeostatic processes, homeostatic mechanisms, and there's probably a whole list of other things. It begins with understanding function and then extrapolating disease from there. In this mindset of altered function versus disease, in the mindset of learning about what constitutes function, you can extrapolate the symptoms. And you can look globally back at your patient, and you can get a sense that if all the labs are negative, or if your physical examination doesn't indicate there's disease, then you have a mechanism to explain the symptom complex to your patients. That's critical to know. You have an avenue. Because sometimes we as clinicians are not going to be able to find any objective evidence of why our patients are symptomatic. They're just bringing to you their symptoms. It'll address the conflicts that you're going to have in your mind about whether to use a pharmaceutical or a medication. It'll allow you to communicate with your patients about the organ or system or mechanism, homeostatic mechanism, that is altered and allow you to sit down and talk to the patient about the risks and benefits of using pharmaceuticals, or the risks and the benefits of just waiting it out versus ordering a test. All right? Many of my patients several of my patients have come to me with frank physical examination which would indicate a herniated disc. Cervical spine, lumbar spine. We wait it out, we use some manipulation perhaps, and their pain gets better, but their symptoms are still indicating that there is nerve root compression somewhere. They have weakness and they have sensory changes. Now, most people would order an MRI and get them to a spine surgeon or orthopedic surgeon as quickly as possible. What I typically would tell my patient is this: are you going to have surgery? Do you want surgery? Yes, no. Here's the risks of having surgery. Here's the risks of not having surgery. From the evidence that I have from my clinical knowledge, my knowledge base, here is the percentage of people that go on to have frank herniations and true neurological damage versus those who resolve on their own. Now, the decision we need to make here and now is not whether or not you have a herniated disc. Based on physical exam, I don't need an MRI to show me that you have a herniated disc. I can tell you what nerve roots impacted, and I can tell you what the risks and benefits are of not having surgery. So we need to decide right now whether or not you want that test in order to have surgery. Because as soon as I make the decision to send that patient to an orthopedic surgeon or a spine surgeon, I have to have an MRI. So I have to resolve the conflict in my mind to whether or not to refer that patient on. And that's going to determine whether or not I order that test. If my patient is clearly in a position where they do not want to have surgery, that they want to wait it out, then I'm not ordering that MRI. Because the MRI's purpose is only to send that patient to the orthopedic surgeon or spine surgeon. And they're not going to have surgery. Why do the test? It doesn't make sense to me, but I have to sit down and explain that and adjust those conflicts between myself and that patient. I have to address those conflicts between myself and that patient. All right, that's a clear-cut example of how we need to communicate to our patient. Another one is inflammation. When we look at manipulation, it becomes a little bit more, it's clearer. But when we're looking at inflammation, if we're looking at other aspects of one's health, it's not so clear. When we look at, I'm going to look at the 5 biggies: heart disease, obesity, diabetes, arthritis, and cancer. Every one, if you look at the basic science literature, every one of these diagnoses, these chronic diagnoses, of which are all on the rise, have an inflammatory link to them. Every single one of them. Obesity, metabolic syndrome, and cancer, all related through inflammation. So obesity, metabolic syndrome, you have insulin, you have the leptins, you have the cytokines. The cytokines and the inflammation changes the growth factor signaling, it changes the vascular perturbations, and it changes the cytokine to brain, cytokine to body inflammation loops. So there's a huge component of inflammation involved with cancer and obesity. When we look at inflammation, we look at it from a couple perspectives. Most of what we learn is that it's a cellular, a humoral kind of approach or complex. What we're seeing now, if we think about function, if we look at the whole function, what we're finding is that inflammation has a neural loop and is greatly connected through the autonomic nervous system. If we look at function of the autonomic nervous system, The reality is that the vagus nerve is very critical to control inflammation in our body. Much like the reflex loop of the withdrawal reflex, when we look at the anticholinergic inflammation pathway, we see that it has the vagus not only has the efferent arm, it has the afferent arm. As soon as the body picks up that there's cytokines in the body, or an increase in inflammation in the body, there's an afferent drive to the brain that turns on and increases vagal tone to the celiac plexus and ultimately and to the spleen, so that that inflammation loop is decreased. And in normal function, we should control, our inflammatory controller is autonomic nervous system, more so than the cellular or humoral processes for inflammation. Now, I bring that to your mind because if you have a patient, I'm talking about altered function, and we look at disease, if you have a patient with heart disease, we know that there's a huge relationship between heart disease and inflammation. We know that there's a huge relationship between decreased or inefficient vagal tone and heart disease. So here's the struggle that we have. When we look at using cholesterol, anti-cholesterol medications, we're going to affect the cholesterol aspect of inflammation as well, the humoral aspect of inflammation. But we're going to decrease the inflammatory capability, we're going to decrease cholesterol, but in doing that, we're going to decrease the patient's ability to control for inflammation, because you have to have cortisol in order to be able to mount an inflammatory response. So it's a struggle. It's a struggle. If you see someone with heart disease, we know that we've been told that we have to use a statin, but on the other hand, we're still messing with their whole inflammatory chain, and now that we have, or their whole inflammatory reflex, and now we have more and more evidence that the inflammation is the biggest reason for the perfusion difficulties in patients with heart disease. So we need to look at the function of the autonomic nervous system. We need to look at the function of cholesterol, and we need to look at the risk factors of our patients within that patient. We need to think about other avenues in which we can help decrease inflammation in that patient with heart disease. It doesn't stop with heart disease. Vagus is important. The vagus nerve is critical for sepsis. They take these little vagatized mice, and if the vagus is completely destroyed, the mice, if you cause a peritonitis, the mouse is going to die pretty quickly. So here's the mouse with a perforated intestine with normal vagus. Here's the cut vagus. The decline rate is very quickly. Here's a stimulated vagus. So we're increasing vagal tone. And you see that that mouse does much better. And that's electronically and then pharmaceutically stimulated vagus. So it helps us to see that vagus is important, very important. With gut immunity, we know that with celiac disease, with Crohn's disease, it's critical. A couple studies, actually some very good studies, have shown that the vagal tone in Crohn's disease is decreased tremendously. Heart disease, diseases of the liver, all related to inflammation. The biggest perpetrator is altered function of the vagus. Now, there's not a disease that wipes out vagus. There's not we don't go through life taking medications that decrease vagus. We don't routinely cut the vagus, right, in our patients. So the question has to think, you got to think when you have a patient with irritable bowel syndrome, if you have a patient with celiac disease, you have a patient with Crohn's disease, you have a patient with lupus, you have a patient with RA, you need to figure out, think to yourself, well, I know this inflammatory cascade normally would be covering them. Something's happened, so their inflammatory load is much higher than it should be because they're either their vagus is decreased or they're just overloading their body with inflammatory substrates. And what could they be, and what can we do about it? It's going to make you think about your patients from an altered function perspective. And it's backed up more and more and more by basic science. Here's all of the things that are involved. So exotoxemia, sepsis, colitis, pancreatitis, hemorrhagic shock, intracerebral hemorrhage, ischemia, poor myocardial reperfusion after injury, renal ischemic reperfusion, so renal disease, post-cardiac arrest, artery occlusion, and arthritis are the biggies. So the cholinergic anti-inflammatory pathway. You all learned that early in medical school. It's an important one to keep in mind. It's a good example of normal function. Thinking about going back to your basic science roots. Going back to your basic science roots when you are addressing a patient that's complaining of abdominal pain. Symptoms of irritable bowel syndrome. Symptoms of myalgia and arthralgia. Symptoms of early onset rheumatoid disease. It changes the way you think about your patients if you think about them from an altered function model. If you think about your patients. You don't think about them, if you think about the disease model, which I think has happened in medicine quite a lot, we end up not curing or not changing and allowing for our patients to continue to exacerbate or have symptoms. Chronic illness is still on the rise, the biggies. And the problem is that you folks are going to be somewhat accountable for the amount of tests that you order, the amount of prescriptions that you write, and the amount of referrals that you do. So you're going to need, and you all are in a great position to learn and to be educated, because you are educated, about a functional model to patient care. Now, I want to go back to the literature, because this is what we're coming up with, what's being stated, and I got these handouts for you. I put osteopathic manipulative techniques in there because what the consideration is vagal nerve stimulation. How do we increase that vagus nerve function? That's the big key. How do we influence it so that our patients with heart disease get better, our patients with Crohn's disease and ulcerative colitis get better? And they're actually implanting vagal nerve stimulators now in rheumatoid arthritis patients, electronically. What do you guys know about vagus? There are other ways to influence vagus within the standard of care. We use osteopathic manipulative technique. If you choose to use osteopathic manipulative technique, it's only going to be to help the patient and understand the role of that technique relative to the stimulation of vagus. Acupuncture, we know, increases vagal tone. That's been well researched. What you folks need to do is research a little bit more about how the osteopathic manipulative technique role of increasing vagal function works for your patient. I don't think that's been done yet. So I have to throw in a couple of A.T. Still quotes for you folks, just to conclude. The practicing osteopath's guide. The osteopath reasons, if he reasons at all, that the order and the health are inseparable, and that when order is in all parts is found, disease cannot prevail. And if order is complete and disease should be found, there's no use for order. And if order and health are universally one in union, then the doctor cannot usefully, physiologically, or philosophically be guided by any scale of reason otherwise. So, if you do everything in your power to restore function, that's your goal. Whatever is in your power, folks. So that may mean communicating to your patient about the role of what they put in their mouth, allowing them to understand the role of an anti-inflammatory diet, because much of our chronic illness is all relative to our huge choices in what we eat in America, and that's growing. A lot of it is what we consume, a lot of high inflammatory foods. Knowing the role of inflammation in those big disease areas, how can you not sit down and have an honest conversation with your patients about the inflammatory components of the food that they eat? And then it's up to them. The role of manipulation in allowing your patients to have improved order or improved function. When I treat my patients with low back pain, I treat them to restore function, not to get rid of their pain. When they walk out of my clinic, they're still in pain, but I've restored order. I've normalized their function. Now it's up to the musculoskeletal system and I trust that the musculoskeletal system will do its thing to resolve the symptoms. So improvement of joint function, improvement in global function, decrease in pain. If you do everything in your power to understand function first, then when you see patients that walk in the door with altered function or a symptom complex of altered function, your job is to do everything in your power to restore function. And then it's up to the body, because you got to trust that the human body is capable of treating itself from that point or taking over from that point. And then the last one is just simply stated, to find health should be the object of the doctor. Anyone can find disease. It's up to you to seek out and figure out where the alteration in function is. That means you need to use everything in your power to diagnose that patient. Physical examination will become more and more and more critical, folks, in the future. We will not be able to, my personal opinion is, with the rise in health costs, we will not be able to depend on allowing lab tests and MRIs and CT scans and x-rays to do the work for us. How we learn medicine now is going to shape the way that our healthcare costs will decrease in the future. We have to believe that. And you folks are wonderfully poised to be able to handle the turbulence along the way. Thank you very much.
Thank you, Dr. DeStefano. On behalf of the ATSU KSOM, the OMM department, and the attending family, we would like to thank you and would like to present this plaque and appreciation to you as well for what you've done for us. Thank you very much. Appreciate it.